Hello friends, this is Sonu, and today we'll continue our discussion of the Parkinson's disease. As I discussed in the last session, that was discussed about the main physiological function of the dopamine, that how it's secrete, how it's released, and how it's bind to receptor, and then finally how it's fired the cerebral cortex, and then finally it's moved the muscles, and which types of brain structure is involved in this disease, and which types of effect are there. That's why the dopamine is decreased secretion, and then finally patient suffering from Parkinson's disease. Today we'll discuss about the anti-Parkinson's drug and how we will treat to the Parkinson's disease patient. So first of all, the classification, that is the very important. That's the pharmacology. So from the classification, actually we have two types of treatment. First, either we have to maintain the dopamine, either we have to decrease the acetylcholine. But approximately the 90% of the treatment we maintain the dopamine. So this is the dopamine and this is the acetylcholine. Means actually the Parkinson's disease patient increase the acetylcholine, decrease the dopamine. So either we have to maintain the dopamine, either we have to increase the dopamine, or either we have to decrease the acetylcholine. But approximately 90% of the treatment increase the dopamine, and the 10% in a treatment we are decreasing the we will decrease the acetylcholine. So means we can say that mostly we have to normalize the dopamine in the CNS. So this drug is affecting on the brain dopaminergic receptor, or maintain the dopamine in the CNS. So from the first, that is the dopamine precursor, means the name is a levodopa. Means one thing also I have to mention before the starting classification, that the patient suffering from Parkinson's disease, the mainly lack of the dopa. Means we can directly give the dopa, but we can't give. Why? What's the main reason? Actually, dopamine, why we can't give? Because dopamine is the polar compound. It's a very charged molecule. That's why it can't absorb in a GIT, and it cannot cross the blood-brain barrier, because the blood-brain barrier even in a GIT mucosa is made by the lipid bilayer. And we can say that the dopamine is a ionized drug, means it will not cross the blood-brain barrier and it will not absorb. Due to this reason, if you give the dopamine, it's just in a peripheral area, it increase the peripheral area side effects and will not enter in the CNS. That's why we can't give the levodopa. That's why instead of the dopa, we are giving the levodopa. Levodopa is a lipid soluble. That's why it's very easy to absorb and very easy to penetrate the CNS, and then it can be go in a neuron, dopaminergic neuron, and can be maintain the dopamine. So let's start from the dopamine precursor, levodopa, or we can say L-dopa. Next one, next drug. This is a peripheral decarboxylase inhibitor. Actually, it's an enzyme. So we can't say that it's a drug that for the Parkinson's disease. We can say that this drug is protect the levodopa, because the levodopa is 90% of levodopa is metabolized, or we can say is destroyed in the peripheral area, and approximately 10% of levodopa is reached in the dopaminergic neuron, but it's not for the sufficient. That's why this drug is a protect in the peripheral area to destroy of the levodopa. How we will discuss about this. So two drug, carbidopa and benserazide, which belong to the peripheral decarboxylase inhibitor. This is the enzyme. Next one, that is a dopamine agonist. This is the very latest drug. Even instead of the levodopa, this is too much or very famous drug, or very popular drug. That is the bromocriptine, which potent act on the D2 receptor, ropinirole and pramipexole. This is the act on the D2 and D3 receptor. Next one is the MyoB inhibitor, very popular enzyme, that is the monoamine oxidase, which found in a human bodies everywhere, which secrete by the mitochondria. So the monoamine oxidase O, it is subdivided into two groups, A and B, and as we know that it's destroys our catecholamine. The catecholamine is dopamine, adrenaline, noradrenaline, and serotonin. So MyoB is mainly destroy dopamine, and the MyoA is destroy noradrenaline, adrenaline, and serotonin. That's why special drug this only block the MyoB inhibitor, MyoB enzyme. That's why the name is MyoB inhibitor. That drug name is the selegiline, rosagiline. Next one is the COMT inhibitor. This is also enzyme that it's also this enzyme destroy the catecholamine. That name is the catechol O methyl transferase. As you remember from the adrenergic agonist that we discussed already about the this all enzyme. And the finally glutamate antagonist, that is the uh, amantadine. Actually, it's an antiviral drug. It's this drug used in the antiviral mainly in influenza A2, but this drug also used in somehow in a anti-Parkinson's treatment, but not drug of the choice, best drug, but in somehow we can use. So how we will discuss about this drug? Firstly, we will discuss about the normal function of the dopa very briefly. As you remember that we eat lot of protein. From the protein it's break down the amino acid, and then amino acid, the branches of the lot of branch of the amino acid. One of the branch, that is the tyrosine. From the tyrosine, the special transport, that is the this is the dopaminergic neuron. So by the special transport it taken up, and then by the special enzyme, that is the tyrosine hydroxylase. So by help of the tyrosine hydroxylase it become dopa, and then dopa decarboxylase, by the help of this enzyme it's become a dopa, and then dopamine will go in synaptic vesicles, and whenever action potential will generate in the neuron, then it's finally secreted in the synaptic area. And the post, this is the presynaptic, this is the postsynaptic. So in the postsynaptic, the receptor is there, D1 D2, it binds to the receptor, and then further the function is move on. So D2 receptor is the G inhibitor, is coupled with the G inhibitory receptor, and D1 receptor is coupled with the G stimulatory receptor, G stimulatory secondary messenger. And finally the both are finally it's excited the thalamus, and then thalamus fire in the cortex area, and then cortex area by the extrapyramidal tract, spinothalamic corticospinal tract, and it's finally muscles the movement. So this is our main function of the we can say dopamine. Now we'll discuss that how drug will go in finally reach in the neuron, and which types of enzyme are interrupt, or which types of enzyme are we can say destroy of the drug. So let's start from the levodopa. So levodopa, as we know that levodopa is the lipid soluble drug, and as we know also that lipid soluble very easy to absorb. So it's absorbed in the GIT, and then GIT by the GIT it's going in the liver will go in general circulation. And as we know that the blood-brain barrier is made by very thick endothelium, that very tight junction means in a large molecule, and the polar compound or negative compound will not penetrate this area. Only very teeny molecule can be penetrated in this area, or which molecule that made by the lipid barrier, because this seal also made by the lipid barrier and to love each other and can be penetrated. So, and one thing also that about the levodopa, we can say the pharmacokinetic, that levodopa should we give, or rather have to take the patient in empty stomach, means food can be interrupt or decrease the absorption. Why? Because mainly the even a lot of food can be decrease the absorb, but neutral amino acid, neutral amino acid can be leucine and isoleucine, leucine and isoleucine. This is the neutral amino acid. This amino acid also absorbed by the same transporter. For example, this is the transporter of the levodopa. The same transporter also it's a transport in the liver, in the general circulation, and then finally it's a CNS. That's why it's along with the food or along with the protein it will take, so it will decrease the absorption, and it will not reach in the neuron. That's why approximately before the 30 minutes or 40 minutes before the meal, levodopa should be take the Parkinson's disease patient. This is very important information that we should know. So levodopa the patient take, and by this transporter it go in the liver. But one thing you have to know that approximately if you giving the 100 mg, for the understanding purpose, if you giving the 100 mg of the levodopa, approximately the out of the 100 mg 1 to 5% or 1 to 4 or 3% is reached on the neuron, and the rest of the amount of the drug are destroyed in the peripheral area. Why? Because lot of enzyme is there and the enzyme destroy them. Which types of enzyme? First of all, the levodopa. Levodopa is going in the liver, but in the nearest of the liver, dopa decarboxylase enzyme is there. The same dopamine decarboxylase which is present on the neuron to help by the dopa to dopamine, which convert to the dopa to dopamine. So the same thing, levodopa will, by this enzyme it's convert to levodopa to dopamine. And as we know that dopamine will not penetrate the CNS. Why? Because it's a polar compound, so it will not penetrate the CNS. It means what will be the effect? Means the person is taking levodopa alone without any combination of the drug, and this enzyme is destroying here, like the levodopa is converting to the dopamine. This enzyme is converting to the levodopa to dopamine, and as we know that dopamine will not penetrate in the CNS. And one thing also know, you can remember from the adrenergic agonist that if you slightly increase the dopamine, it will act adrenergic agonist, means it will function on the adrenergic neuron. So dopamine will function in adrenergic neuron, and it's affecting on the heart. It will bind on the, in a heart it will bind on the D1, and then in a vasculature, smooth muscles, for example in a mostly in a venous smooth muscles, which has D2 receptor, and D2 receptor is coupled with G inhibitory, and D1 receptor is coupled with G stimulatory. Means whenever you stimulate the D1, it will affect the positive, it will stimulate, and whenever you will stimulate D2, it will inhibit the, like inside the cell it will signal to inhibitory signal. So by dopamine will increasing in a peripheral area, and it act on the heart, and it act on the D2 receptor. Means what will be the final result? Means cardiac arrhythmia can be developed because of D1 receptor stimulation, and inside the venule, means the veins smooth muscles, due to the decreasing the D2 receptor, by the stimulating the D2 receptor, it dilating, and postural hypotension can be developed, means orthostatic hypotension. So what is the effect? Postural hypotension can be developed. Why? Because of dilating the smooth muscles, because that smooth muscles has D2 receptor, and as we know that D2 receptor is the inhibitory receptor, because it's inside it's coupled with the G inhibitory protein, and D1 receptor is coupled with the D stimulatory protein, and it's present on the heart. So cardiac arrhythmia can be developed. It can be extrasystole, it can be SA no tachycardia, AV no tachycardia. It depends upon the drug concentration of the dopamine. So but the Parkinson's disease patient not then they don't want to like that effect. They have to, this levodopas have to go in the, should be go on the neuron and they maintain the dopamine. But this is the nasty enzyme is not doing like that. It's converting your dopamine in the peripheral area. That's why a special drug are already made, that is the carbidopa and benserazide. Actually this drug is block this enzyme. So always, nowadays always levodopa will not give alone, always with combination, either it combination with the PDI, either with MAO inhibitor and COMT inhibitor and some other drug. So let's see that this enzyme, how this enzyme inhibitor drug, how it help to the levodopa. So we inhibit already by this drug carbidopa and benserazide. So we inhibit here. Means now by this enzyme no any problem, this enzyme already inhibited. But some other enzyme also that create the problem, will create the problem. With which enzyme? That enzyme is the COMT. COMT, this is the catechol-O-methyltransferase. This enzyme also destroy the levodopa. Okay, by this inhibit this enzyme, no problem by this enzyme. But what about this enzyme? This enzyme also inhibiting the levodopa. So actually what this enzyme, the levodopa is going blood, general circulation, and this enzyme is methylated. It's methylated and finally make 3-O methyl dopa. And 3-O methyl dopa will not, we can say it's not dopamine. It's not act as a dopamine. So it will not. It's, we can say, inactive. It will not active. So levodopa by this enzyme, it by help of this enzyme, it become a 3-O methyl dopa, and we don't need this molecule. We need only dopamine. So finally, the decreasing the dopamine means the levodopa will not reach in the neuron, and the finally decrease the concentration of the dopamine in the CNS. That's why we have some other drug also that inhibit this enzyme. The name of this drug, that is the entacapone and tolcapone. The two drug, entacapone and tolcapone. This drug is inhibit this enzyme, and now levodopa has no any problem with the two enzyme. We already inhibited by dopa decarboxylase, and also we inhibited the COMT. So now no problem with these two enzymes. But one enzyme we have also other to create the problem. That is the MAO, monoamine oxidase. Firstly about these two drugs very briefly. Tolcapone, what is the main function of tolcapone? Actually tolcapone, it can penetrate the CNS, so it can inhibit the COMT in a peripheral area, as well as it can be inhibit in the central area. Means this enzyme present in a central area as well as peripheral area. So tolcapone, toll means, we can say it's a very long, so it can be penetrate inside the blood-brain barrier and can be reach the neuron. By this word you can understand. So tolcapone can be penetrate CNS, and it can be inhibit the both area in a CNS COMT enzyme and in a peripheral area COMT enzyme. That's very potent. But one problem is there. It have liver toxicity. By the L, you can understand by the L, liver toxicity. But entacapone has no any liver toxicity, but one negative effect, that it will not penetrate the CNS, but the highly amount of COMT in a peripheral area, not in a CNS area. So it will not too much, we can say, create the effect. And we have to also maintain on that time that when our doctor is treating to patient is depend upon the severity of the Parkinson's disease patient. Like it's too much need the dopa, or if you just a little bit stimulate, that it can be normalized. So it's depend upon the situation. So about this two drug. Now we already inhibit the COMT, we already inhibit the dopamine decarboxylase. One enzyme we have to inhibit also there. That is the MAO B inhibitor. So MAO B inhibitor, that is the selagalin and rosagalin. So for example, MAO enzyme is here. So if you inhibit the monoamine oxidase, now no any problem. Now levodopa can very smoothly absorb in the GIT. It can go in a liver, it can go in a general circulation, and it can go in a it can cross very smoothly in CNS area, and then levodopa can be go in the neuron and stimulate the dopa, and then dopa will finally further move in a dopamine, and then dopamine bind in this area. But what we have to think, that what we have to do on the time, means if you adding the enzyme inhibitor, it can be PDI, it can be MAO B inhibitor, it can be COMT inhibitor. On the time what we have to give, you have to decrease the levodopa dose. If you don't decrease the levodopa dose, and by the combination with this drug, levodopa will very rich accumulation on that neuron, and it will increase the dopamine. Means in the Parkinson's disease patient suffering from hypotonia, means decrease the muscle tone, they will not normal movement, dyskinesia or bradykinesia, rather we should say bradykinesia, decrease the movement. But if you not decrease the levodopa, the concentration or dose of the levodopa, you will not decrease along with this combination drug. So dopamine, the finally dopamine, it will be increased in the CNS area, and the just opposite effect, hypertonia can be developed, dyskinesia can be developed due to excessive dopamine release. That's why you have to very properly, or we have to very carefully decrease the amount whenever you combination with the enzyme. It's depend upon the, if you the combination with three enzyme by the PDI, MAO-B and COT inhibitor along with the levodopa. So very little amount of the levodopa you have to give. If you just adding the carbidopa with levodopa, so you have to little bit increase the amount, but not too much. But it depend upon the condition and it depend on the patient situation. So already we discussed about the enzyme inhibitor, PDI, MAO inhibitor and COMT. Now let's discuss about the direct dopamine agonist. Bromocriptine. Bromocriptine, it's a ergot alkaloid, and the ropinirole and pramipexole, it is a non-ergot alkaloid. So this is the, we can say, important information. Ergot alkaloid means they make from the fungus plant. So it's a, the side effect is significantly more as compared to the non-ergot alkaloids. So bromocriptine, it's a ergot alkaloid, ergot alkalosis, and the ropinirole, we wrote shortcut, ropinirole and pramipexole. These both are non-ergot. Actually, difference between ergot and non-ergot. Ergot alkaloids, if you give the ergot alkaloids, the side effect is slightly more, and if you give the non-ergot, it will not affect on the, like in the mostly liver area, in the liver part, and such other also side effects will be, as compared to the ergot, it will decrease, or we can say not too much. So it's very helpful or very pleasant drug for the long lasting use. So these two drugs, so actually this drug is not act on any receptor, it will not any stimulate, and it will not any help to we can say convert to dopa to dopamine. It will just act on the postsynaptic, it will not act on the presynaptic, it will act on the postsynaptic where the D2 receptor is already present. So it will stimulate the D1 receptor, it will stimulate the D2 receptor very slightly, we can say very slightly act on the D1 receptor, not significantly, mostly act on the D2 receptor and D3 receptor. Actually, about the dopamine receptor, we have 4 D1 to D5 receptor, D1 to D5 receptor. So, and 2 family, D1 family and D2 family. In D1 family have D5 is act as like D1 family. Why? Because it's also coupled with G stimulatory. And the D2, 3, 4, 2, 3, 4. The 3 and 4 act like a D2 family, means it's coupled with G inhibitory protein inside the cell. So D1 and D5 is just like a D1 receptor because it's stimulatory receptor. It's coupled with the G stimulatory. D2, D3 and D4, these dopamine receptor are coupled with G inhibitory protein. So we can say it's a D2 family. The same thing here, the ropinirole, it's the bromocriptine act on the D2 receptor, and the ropinirole and pramipexole also act on the D2 receptor as well as D3 receptor. As I said, the D3 receptor just like a D2 family, means you can see that it also affect stimulate the D2 receptor. So these 3 drugs are stimulate the D2 receptor and maintain the dopamine level. So if any drug, or we can say the neuron become already destroyed, no any neuron is there on the time, levodopa will not act. Means levodopa will if person will take levodopa, so finally it will go and it will help to uh, stimulate the dopa, and dopa will finally convert in a dopamine. But about this thing, the neuron should be there. Without neuron it will not act, because this all reaction are going on inside the neuron. That's why neuron is need. But the Parkinson's disease patient destroying the neuron, approximately we can say that 70 to 80% of the nigrostriatal dopaminergic neuron are destroyed or lost. Only 20 to 25% neuron are there. So due to the drug, due to the levodopa, it's stimulating the 25% of neuron, and by the helping of this drug, it can maintain the levodopa level in the brain in a normal amount. It can normalize the dopamine by the 20% of the neuron by the help of the levodopa. But in some patient, very severe patient, in exception we can say 1/3 of the patient and levodopa is very good working. 1/3 of the patient is moderately or mild and moderately working. But in a 1/3 of the 1/3 of the patient will not act, no any action, no any benefit you can see. You can't see any benefit. Why? Because almost all neurons are already destroyed. On the time if you give the levodopa, there no any positive effect you can see. On the time you have to give the DO agonist. Why? Because it will not act in any reactions. It just stimulate the receptor and maintain the dopamine. That's why this drug nowadays, instead of the levodopa, this is very good drug. Even the monotherapy, initial treatment of the Parkinson's disease, during the initial treatment, doctor should be prescribed this drug instead of the levodopa. And the next one we have to discuss the glutamate antagonist. This is the amantadine. As I said, that amantadine is the mainly it's act in a like used in the antiviral drug, that is the influenza A2 antiviral therapy. But this drug also used in the stimulation of the dopamine. Actually, this drug is increase the secretion of dopamine, increase the release, and decrease the reuptake. As we know that whatever amount of DO is released in the synaptic vesicles, then finally it's reuptake to the new synthesis by the reuptake 1 mechanism. Here is the reuptake 1 mechanism. So amantadine increase the secretion, increase the releasing, but inhibit the reuptake. By this method, it's maintain the dopamine in the CNS area. But one bad thing about the amantadine, actually it's a very initially stage is develop the tolerance, and then effect is a gradually loss. That's why we can't use in a long term of the amantadine, just for the 2 month or 3 month. After that we have to stop, otherwise it will affect start the tolerance, and then finally the action is gradually lost. That's why it's not drug of the choice, but somehow we can use amantadine. So already we discussed about the main mechanism, we discussed about the how we will give the drug, and you can understand that which drug is the Parkinson's disease. Mostly we can say it is the drug of the Parkinson's disease. If you just give carbidopa and benzodiazepine, it will not any effect. The patient will not treat, the patient will not feel anything. The same thing, just some side effect can be, because this is the drug, so obviously if no any action will there or action will there, side effect automatically it have to. The same thing MAO-B inhibitor. If you give just along the MAO-B inhibitor, no any changing in the Parkinson's patient, just except side effect. The same thing here. Levodopa, dopamine agonist, and glutamate antagonist. These three we can say this is the main real Parkinson's disease, the drug of the Parkinson's disease. That it's actually this drug is the maintain the dopamine. In anyhow it's go by the levodopa, by the here in a neuron, stimulating the neuron reactions, and by this method in increasing the dopamine agonist stimulating this area postsynaptic and maintain the dopamine, and the glutamate also the same thing, it's increasing the dopamine and releasing the dopamine. So these three group of the drug, we can say that it's a main drug of the anti-Parkinson. And these three drug, the enzyme inhibitor drug, this drug is the protect of the levodopa, and this actually not protect this D agonist. This protect only levodopa. It's a help to or prevent to destroy in the peripheral area and try to large amount of the reach in the neuronal area. So we discuss about the main mechanism, that how this drug is the influence of the dopamine or increase the concentration of the dopamine. Now we will discuss the what could be the side effects, what could be the contraindication. The side effect almost the same, because if you side effect means if you increasing the dose, means if you increasing the dose of any drug, means you increasing the concentration of dopamine in CNS, and whenever dopamine will be increased in the CNS, the side effects the same side effect will be there, because all drug is finally, if you influencing the dopamine, it will affect the same. So let's discuss first side effect of the levodopa. Side effects. Levodopa. Initiations of therapy means you are starting the therapy. So in the starting time, actually this drug also act on the chemo trigger zone, which maintain our we can say emetic system, that if you stimulate the chemo trigger zone, nausea, vomiting can be occur. So in a starting therapy, nausea can be, vomiting can be, as I said, the tachycardia. Why tachycardia? Because of if you, but it's mainly whenever you using the alone, or in somehow if the main maybe carbidopa will not act properly. So increasing the dopamine in any case, if you increase the dopamine concentration in the peripheral area, then it can be obviously affect on the cardiac area. Why? What's the main reason? Already I discussed tachycardia. Postural hypotension. Why? The also thing I said, because it act on D2 receptor. Postural hypotension. In some time, the taste, changing of the taste change. So these types of effect in a starting treatment, but during the long treatment, means the Parkinson's disease, till the person is alive, they have to take the medicine, anti-Parkinson drug. So after the, we can say 4 to 5 years of the treatment of the levodopa, the effect was very we can say after the 5 minutes, after the 4 to 5 years of the treatment, the effect, positive effect, it's very less, and the negative effect very high after 4 to 5 years. Means we can say the person become 2 hours before the start the treatment. Why? What's the reason? See, I will explain this very deeply. For example, this is the CNS, the cerebellum. This is the substantia nigra, and they are innervating the neuron. This is the neuron, and this area is the, we can say, which D1 and D2. So as I said that approximately 80%, 70 to 80% are neuron already destroyed, and the 20% of neuron is there. But this 20% of the neuron is still destroying, means progressive destroying. Still they are destroying. So after for example, you start now from today, the person is taking levodopa. After the 4 to 5 year, the effect is very negative, and positive effect is very negative, and the side effect is more, and the effect is uh, very slow, or we can say very less effect and very high side effect. Why? What's the reason? As I said that the 20% of the neuron is remaining there, they also start to destroying, they're still destroying. So after 4 to 5 years, it become a, we can say 5% of neuron will be there, 5% neuron is there, and 95% neuron already destroyed. But on the time, if you the same amount of the levodopa a person is taking, but here is the very less amount of the neuron is there. That's why they will, because the levodopa is act on the neuron, it will not act on the particular receptor. And it act on the neuron, and then neuron will further help to synthesize the dopamine by the dopamine decarboxylase. For example, the dopamine is initiate, and then dopamine will make the dopa is eventually made by the dopa. So by the inhibiting or by the destroying of the 5% by the neuron, but you taking, the person is taking the levodopa in the same amount, on the time they will not act here very properly due to the decrease the neuron, but effect, side effect is very high. Why? Because you taking the levodopa, and levodopa is going, the accumulation on the body is not any acting due to the decrease the neuron, but it's accumulating and accumulating, and due to the accumulation of the levodopa, its side effect is very high. Due to this reason, the levodopa after 4 to 5 years to become too worse. What would be the side effect? See, first side effect is the dyskinesia. Dyskinesia, it can be tremor, it can be akathisia, or it can be chorea, means abnormal movement. They can't, we can say, maintain the on movement. So chorea, the name is chorea. And one effect, that is the on off effect, we can say the abnormal fluctuation of the motor movement. So the name was on off effect, or we can say fluctuation of motor area. What is the on off effect? For example, as I said, that is progressively destroying the neuron, like the 20% of remaining is the neuron is there, but it's still destroying. On off effect, for example, the person is taking levodopa 4 to 5 times a day. So 4 to 5 times a day means now it take levodopa, and the levodopa will reach in a CNS. For example, this is the CNS. It reach in a CNS. Sorry, it's a L. So this is levodopa. It's reach in a CNS. And after 1 hour, the person have to take again levodopa. So after 1 hour, they already take levodopa, and the drug is still in a stomach. For example, it's a stomach. So starting, the person take levodopa reach in a CNS, and after the 1 hour, the person already again dose they take, and this drug is the absorbing right now. They are still absorbing in the CNS. Means this levodopa which take before this drug, the action is progressively slightly decreasing this action. Why? Because they take before 1 hour, and then after 1 hour they already took this drug, but this drug in absorbing in the we can say in a stomach. After maybe 10 minutes, it will finally reach in the CNS. So between that gapping, which between the 10-minute gapping, this 10-minute gapping, in this gapping, the off effect will be there. Means off effect means the person is in a frozen condition. They even can't move, like that they're standing. They can't blink the eye, they can't move the facial muscles completely. They stand on, we can say, frozen movement. Sorry, it's not movement, frozen standing. They will not even uh, like any muscles movement, very stand position. They can stand between this 10 minutes. And after 10 minutes, whenever this the next levodopa will reach in the CNS, then on effect, and then finally it's move and normal condition can be there. So this is that this mechanism or this problem is can be say on off effect. For the 10 minutes it can be off, for the then 10 minutes it's on. So fluctuation of the motor area. But how this problem will be treated? On the time, what we have to do? On the time, if the person is taking 4 to 5 times in a day, so we should increase the amount of the schedule, means 10 to 5 to 10 times, 10 times a day we should give, due to less on off effects are there. If you increase this type of dose, then you can uh, the person or the patient can be feel better. They will not very increase amount of the on off effect, or very fastly this effect will not there. That's why nowadays levodopa is not, we can say, not best drug. Best drug is the direct DO agonist. This drug will not any effect on the on off effect, because it act on the direct receptor. It will not act on the neuron and all thing. So I said already the effect: nausea, vomiting, tachycardia, postural hypotension, and taste change in the starting treatment. Later, dyskinesia, tremor, akathisia, and chorea, on-off effect, and function of the motor area. One thing also effect is there. That effect is the as we know that dopamine neuron, that is the nigrostriatal dopaminergic pathway. By this pathway the dopamine is secreting. But along with this neuron, we have in a brain have also another pathway, that is the mesolimbic system. Means from the CNS it go in a limbic system. So other pathway of the dopamine, mesolimbic system. Mesolimbic system. Mesolimbic system. In this from the CNS, dopamine take from the CNS and it go in a limbic system. Limbic system. In this system, very potent dopamine stimulator, as well as also in the hypothalamus and in the thalamic area, because thalamic area already by the nigrostriatal pathway eventually act on the thalamus. So by the limbic system, and as we know that limbic system is concerned our emotion, behavior, and memory, short-term memory, and some other thing. So for example, if you increasing the levodopa, here not I'm talking about the treatment like the prolonged treatment effect. I'm talking just about if you increasing the levodopa concentration, or if you combination with this drug, and if you not decrease the levodopa, means the concentration of the dopamine in the CNS is very high, and dopamine will not act in only in a nigrostriatal pathway. It's a dopamine wherever the dopamine receptor is there, it will act on the receptor. Either it's a nigrostriatal pathway, either it's a mesolimbic pathway, or either is some other pathway which is the dopamine receptor is there. So, and as we said that limbic system is a very potent dopamine stimulator. So what will happen if increase the dopamine, means it will increase or stimulate the mesolimbic system, and these types of emotion, behavior effect, memory will be interrupt or will be increased. So we can say psychiatric problem is there. Psychiatric problem will be developed. Psychiatric problem will be developed. What could be psychiatric problem? It can be anxiety, it can be delirium, it can be hallucinations, it can be suddenly excitation, and maybe insomnia, sleep disturbance, and so other problem can be developed. Like whatever function of the limbic system, they will all interrupt. It can be any function which uh, initiate from the limbic system, that can be interrupt, or it can be problem. That's why the any patient who's suffering from Parkinson's disease, the doctor should be very carefully have to treat, or very carefully have to see that what amount of the dopamine they should take, or either doctor have to give, and which types of drug combination should be give for the patient. Otherwise, if you don't diagnosis well, and if you give the very high drug, high potent drug, that can be stimulate too much dopa, so these types of effect you can be see. That's a very carefully have to treat. So we discussed about the levodopa. About the side effects, already we discussed that what could be the side effects in a heart, what could be side effect in the vein. Now we'll discuss about the contraindication, because a lot of contraindication of this drug. So contraindication. Contraindication. Contraindication, first of all, the psychotic patient, it's a strictly contraindication. Psychotic patient means in a psychotic patient, the person will take antipsychotic drug. Means this drug will inhibit the dopamine. For example, clonazepam. Clonazepam, it's an antipsychotic drug. It's a potent inhibitor of the dopamine. So if the psychotic patient will take the anti-Parkinson's drug, means the anti-Parkinson drug just the opposite. They increase the dopamine, and the psychotic patient have to take that drug which decrease the dopamine. That's why strictly contraindication. Next, heart disease. For example, heart is like ischemic heart disease, or some other myocardial infarction. On the time should be avoided, because of if they increase the dopamine, the drug will act on the cardiac, and the arrhythmia can be developed. And any patient who suffering from heart disease, this types of effect is not helpful, is not good for those patients. That's why it's contraindication also. Then glaucoma. Why glaucoma is a contraindication? As I said that the dopamine, if it slightly increase the dopamine, it's act as a adrenergic neuron, adrenergic agonist. And adrenergic agonist release the norepinephrine like catecholamine. And as I said that catecholamine is act on the receptor. It also act on the receptor. And in the eye, the ciliary muscles has beta 2 receptor. So the noradrenaline and adrenaline is bind to the B2 receptor and dilated the pupil. So if the patient suffering from the glaucoma, it's a increase the intraocular pressure. So it's a very painful, and it's a very, we can say, risk condition or dangerous condition for the glaucoma. It can damage the eye also. That's why it's strictly contraindication, because the glaucoma need constriction of the pupil, not for the dilation. So psychiatric patient, heart disease, glaucoma. Then allergic reaction also should be avoided. Allergic reaction. So this is the main contraindication. Should be avoid the anti-Parkinson drug. About the levodopa. Next we'll discuss about the benzodiazepine and carbidopa, the side effect. Indication, as I said, that it's all drug is used for the Parkinson disease. About this is no drug about the Parkinson disease. This drug is to protect the levodopa for the destroy them in the peripheral area. So effect, side effect is not very high. It's a effect just in a peripheral area. That's nausea, vomiting. Most probably nausea and vomiting can be there. About the D agonist, that is the bromocriptine and ropinirole and pramixirole. So first we'll discuss bromocriptine. Actually, bromocriptine, as I said, that's ergot alkalosis. Ergot alkalosis. So effect nausea vomiting is the common because it's a act on the chemo trigger zone. That's why nausea, vomiting, then sometime hallucination, and as a levodopa effect. Levodopa effect. Why? Because if you're increasing the dopamine in the CNS, if you increase the this drug concentration of this drug is increased, means it's finally also act on the dopamine. So the dyskinesia, the hypertonia, and some other effect due to increase the dopamine can be there. So this effect in this drug, and hallucinations also is there because of the its ergot glucose. So effect is more as compared to ropeneol and pramipexole. So let's discuss about ropeneol. Ropeneol and pramipexole. This two drug, we can say nowadays, is very popular drug and very useful drug due to lack of side effect, due to not its act any, we can say, any neuron just direct act on the receptor, and this drug has no any on off effect, like it's not act on the fluctuation of the motor system, because it will not act on the neuron, it's just act on the dopamine. And it also non-ergot alkalosis, means the effect of the ergot alkalosis is disappear in this condition. So just we can say nausea, vomiting will be there. Sometime the change the taste change. And if you increase the, finally as I said, that if you increase the dopamine, the effect will be the side effect will be the same in a levodopa case, in a bromocriptine case, in some other drug case, if you increase the dopamine. But if you normal amount of drug, this effect is common and no any other effect can be there. The next one, myo inhibitor and COT inhibitor, the same thing as I said, that it's not drug, it's just protect of the levodopa. That's why the effect on just in a peripheral area, it will not penetrate, just penetrate the tolcapin in the CNS area. And one thing also, that it's a effect on the liver, is a very exception. We'll discuss about this drug. The sertraline and rosaline effect the same thing, nausea, vomiting, and some other peripheral effect can be, but not very significant effect. About the COMT inhibitor, first we'll discuss tolcapone. Tolcapone, it's a penetrate the CNS because very lipid soluble. Even lipid this also, but it's not too much lipid that it will not penetrate the CNS. Tolcapone will penetrate. One benefit, it will inhibit the MAO in a CNS area and peripheral area. But one bad thing, that L from the liver. It's a liver toxicity. That's why any patient who's suffering from hepatotoxicity or any hepatic pathology, on the time this drug should be a contraindication. That's why you have to remember. And the effect will be the almost as a PDI and the MAO inhibitor, almost the same. About the glutamate, that is the amantadine. Actually act on the N-methyl D-aspartate, NMDA receptor, that is the glutamate receptor. So mechanism, as I said, that it's increase the secretion, increase the release, and decrease the reuptake. That's why it maintain the dopamine in the CNS. But due to the develop the tolerance and then eventually gradually lost the effect. That's why in a long lasting, this drug is not used for the long lasting, very short time. Effect is it can be insomnia in a high dose, nausea, vomiting, sometimes hallucinations. So this effect is common effect. Even all dopamine receptor is the common. Some effect is the change exception, but all the same. Then finally, now very important information, that whenever the dopamine, that this some author said and some person also said, some patient said, that it's a also very rare and very exception, that whenever the dopamine is catabolized, dopamine is catabolized, if this dopamine catabolized, and whatever amount of the catabolized, that molecule or that part, it's we can say going to destroy the neuron. Some theory they said that the on dopamine receptor, whenever dopamine is catabolized and whenever it's a, we can say after the catabolization, the whatever amount, whatever the molecule are there on the CNS, that molecule are going to destroy the neuron. Means already the Parkinson's disease patient suffering from destroying the neuron, and this drug is also going to destroy. So this is the bad information, but it's very rare, and some theory they said. But some of the drug is very good. For example, ropeneol and pramipexole. This is the neuroprotector drug. Neuroprotector means in one side this drug is maintain the dopamine in the CNS. Another side it's protecting the neuron. Means it's very useful that the Parkinson's disease patient already has we can say very progressively decrease the neuron, destroying the neuron, and this drug is protect the neuron. So the anti-Parkinson's as well as neuroprotector drug, this drug is protect our neuron. And the some drug also that rosagiline, this drug also they protect the our neuron, but some also said that protect the neuron, but exactly we don't know it protect or not protect. So I think this is our main, we can say the main treatment or most widely treatment that nowadays are treating the patient by this all drug. So this is about the main anti-Parkinson's drug. In the next session we will discuss anticholinergic, that this the drug acting on the CNS, that is the anticholinergic drug, that by this drug how we will treat the anti-Parkinson's patient. But 90% of the drug will which treat by this drug, and the 10% of person which is an exception or maybe some other problem, that we have to increase the acetylcholine level, and some other due to maybe this drug is a contraindication, the all drug is maybe contraindication or some other problem, on the time we can use anticholinergic drug. So hope you will understand about the anti-Parkinson's drug. In the next session very soon we will discuss about the anticholinergic, and then we finish the anti-Parkinson's drug. Thank you so much.